My name's Kathy Maupin. I am an MD. I specialize in OBGYN and the care of perimenopausal and menopausal women. Today I'm here to talk about osteoporosis, which is one of the things that has become very important in the last few years for us to talk about with women, because finally, after all these years, we have a treatment besides hormones to prevent osteoporosis. This is one of the things that causes women the most problem in our later years, usually after we're 60, yet we can start preventing it in our 50s and even in our 40s if we're at high risk. Many of us are high risk and don't know it. I thought that I would be immune from that because I am dark skinned and I have dark hair, and I have half of my genetics from a Southern Italian heritage, yet my bones are from my mother, which is from Lithuania, which is very thin-boned, and I started out with being not a non-milk drinker, so by the time I was 42, I had osteoporosis, or actually osteopenia. Now, the definition of osteoporosis is that we have two standard deviations, meaning that's a statistical term, away from the normal young, healthy bone. Now, that means that we are lower by two standard deviations, and that puts us at risk for fracture. If you are told that you have osteopenia, osteopenia means that you are down one standard deviation, not quite as bad as osteoporosis, and that someday, if you continue along the same path without a treatment, you will in fact have osteoporosis and break bones from just normal activity. Now, because of this danger, and now that we have medication to treat it, all of a sudden it's become something that's in the news. And all of a sudden, most importantly, we've decided to compare ourselves with young, healthy normals. Now, in medicine, we don't always do that. Sometimes labs are compared for our average for our age. If we did that, everyone would be okay and would not have osteoporosis, because it's normal to have osteoporosis by the time you're 65 or 70. Therefore, we've now had a new definition. Our definition is now compared to young, healthy, normal bones, and we also have drugs that can treat it. In the past, these drugs were just estrogen or progesterone, testosterone. All three build bone. When we have thin bones to begin with, and these hormones start dropping in our 40s and 50s, then we become at risk for osteopenia, and our bones get thinner and thinner. We can start replacing calcium, and we can start doing weight-bearing exercise. Both of those things help our bones, but if we don't have hormones, if our ovaries have been removed, or if we don't have a good lifestyle, if we smoke, if we use steroids, if we drink a lot of alcohol, then our bones are wasting every day. And therefore, we somehow need to counteract that. In the old days, we treated women with estrogen, and quite liberally. Therefore, there wasn't quite as much osteoporosis by the time they got to be 65. Now, a lot of women choose not to take hormones. And because of that, we have now another drug. One is called Fosamax. That's one type of drug. We also have a drug called Boniva. They are different only in that the drug companies say they're different, and they say one's more effective than the other, but in fact, it's a different dosing schedule. Fosamax used to be a daily drug, but it caused some irritation of the stomach, so we chose not to give it to people who had ulcers or who had hiatal hernias. It also had a difficult dosing regimen, meaning you would have to take it and sit up for at least a half an hour after you took it, or stand up, because if you were to lie down, it would harm your esophagus and harm the upper part of your stomach. Therefore, many women couldn't comply with this. And you can't eat, of course, for half an hour after you take this, so many women couldn't do that and get out the door and go to work. So because this was such a compliance-needy drug, we found another way to give it, and that was once a week. So that became much more friendly to most people. It didn't irritate the stomach quite as much because it was only once a week. And most women could take it even if they had stomach irritation or ulcer disease. Because of that, we developed a way to screen women because now, of course, we have a disease. We know how to measure it. So we all developed a way to do a screening process, which is a bone density test. Most insurance companies will pay for it after the age of 50. Not everyone will pay for it after the age of 45, which is when we like to get a baseline of someone's bones. And if they're high risk, like I was for other reasons, like having your ovaries removed, we like to get the baseline early in the 40s. Therefore, we can know who's going to need these medications and take other action like hormones, calcium, and exercise. So having said that, if you were someone who came to my office and you were 50 and I was doing a preventive medicine type visit or a well woman visit, I would ask you if you'd had your bone density test yet. And if you said no, then I would order that. I have my own machine, so I would have it done at my office. And then I would look at it and see if you were normal, osteopenic, or osteoporotic. If you're normal, good. Good for you. You've done the right things, and you can thank your mom and dad because you have good genetics. You probably were a milk drinker as well. We would repeat your osteoporosis testing 10 years from the time of a normal test if we tested you in your 40s. That's because you're not going to go from normal to osteoporosis in 10 years. You may just start going to a slightly thinner bone, and therefore we have our warning sign and we can treat you. Now, if you are tested in your 40s or early 50s and you have osteopenia, that is our warning sign. So we would ask you to do the preventive things. Start exercising, start either drinking milk or taking calcium. It may be that American women have too many sodas in their lives or coffee or do not have enough exercise, but we have thinner bones for the amount of calcium that we take. However, we would still recommend calcium with vitamin D. Now you would think that we would all get enough sunshine since we're all sun lovers and we are usually outside, but now we use very high SPF sunscreens. Because of that, that gives us a lack of vitamin D. So either you should take a risk and not always wear sunscreen and sometimes go out and just sit in the sun, or you should take vitamin D to supplement your vitamin D. So we've kind of made our own problem. However, we need vitamin D, calcium, exercise, and hormones of some kind, and short of that, then you have to take a different type of drug if you can't take hormones. The therapy for osteoporosis and osteopenia is to use a bisphosphonate, Fosamax, Actonel, or Boniva. And the only difference is the difference in when we give it and how we give it. It's always given on an empty stomach, however, and it is always given such that you don't eat for half an hour afterwards. Most women can comply with this once a month, and that keeps their bones nice and healthy. If that is how you're going to be treated, then you should have a bone density and then have it tested in a year to see if that treatment's working. If it does not work, then your physician should either change gears or add something. You may need vitamin D, and you can have your vitamin D tested. You may, in fact, need IM Fosamax. It has a different name, and that would be given by a specialist. I actually refer to a specialist who does just osteoporosis if I get to the point where you need IM injections for your osteopenia or osteoporosis. Now, let's talk about what this would do if you didn't treat it. First of all, if you have osteopenia or osteoporosis and patients go, well, why should I even treat this? You know, I probably will be dead by the time I'm 70. Well, you may not be. And even if you are living by then, you can't change gears and go backwards and then treat it and get as much effect. So I'd like to prevent this. Then I would also like to give you the scene of what happens if you don't do this. It's not just about breaking hips. The first thing to go is your spinal column. It gets very, very thin, and then it crushes. The bones get very friable. They start breaking, and then they crush the column and squeeze your nerves. That gives you sciatica and spinal stenosis. Those are all changes that are very, very painful, very hard to have fixed, and you can't have bone transported in to make this better. There's nothing that they can put in there short of a very unusual operation done by only a few people in the country that will fix this. Therefore, I suggest, because your back goes first and the back can be painful, that you fix this early on and you never let this happen to you. If you then fix your back, but for some reason had thin bones in your hip, like you were a runner, you did marathons, you thought that was healthy. It was for your heart, it's not for your hips. So when you get to a certain stage, your bones, your hips hurt, or you need a hip replacement. Well, God forbid, hip replacements are never as good as what God gave you in the beginning. Therefore, I would prefer to have my hips be my hips on the way out of this world. So I would prefer to prevent it by keeping my bones thick. Now, hips are just a little different in that weight-bearing exercise really does affect how thick your bones are in your hips, but you need calcium, vitamin D, and either hormones or Fosamax or one of these other bisphosphonates. If you take just one of them or do one of the things, then you may not get your hips to respond. So that should also be followed as well. It's very unusual, but sometimes I see hips thin before the back thins. Now, an interesting story is when I had this thing happen to me, I thought, well, I'm too young, I'm the wrong skin color, I'm the wrong heredity, this can't be me. But I went ahead and took hormones, and within 2 years of taking estradiol and testosterone, I went to my physiatrist, who is a wonderful DO physician, and he takes care of muscle spasms, or if you were to have a ruptured disc or something like this, he helps the pain. He does pain management. He sees all of the secondary problems from osteoporosis. So I had a back spasm. He did an x-ray. He put the x-ray up, and he thought it wasn't mine. He didn't have his cheaters on. He's about 40. He didn't see my name on the x-ray, and he says to his assistant, Vanessa, it's the wrong x-ray, wrong patient. And he's a very nice guy, but she's like, no, this is the only one of these x-rays I've done this week. And he said, really? And he looked, got his cheaters out, looked at my name, and he said, I want what you're having. Because I had gone from osteoporosis, osteopenia, to thicker bones than I should have at my age. He thought it was somebody who was a lot younger, maybe 29 or 30. And that is without bisphosphonates. That's with just estrogen and testosterone. And if you really think about it, men don't get osteoporosis until they're quite old. That's because testosterone gives them thicker bones to begin with. If you've ever lifted a girl baby and a boy baby of the same age, you'll always feel the boy baby be heavier and denser, even if they're a little bit smaller, because they have heavier bones and muscles. That's just what testosterone does, and it works early. And it works for a long time until they go through andropause in their late 50s or 60s. So their bones don't thin until their late 80s. So they have a real leg up on us on this. But when I replaced or had my testosterone replaced, which was necessary for my life anyway, it had the happy side effect of giving me very, very dense bones. So I don't have to take Fosamax or bisphosphonates. And I have it tested, and I always have over normal for young, healthy, and for my age. So that is another option, one that we discussed during the talk about hormone replacement therapy and menopause. So it's not always that you have to take a bisphosphonate. Now, some of my patients refuse to take anything. I don't suggest that. I beg them not to do that. I think that in the end they'll be unhappy, but if that's their choice, that's their choice. It's free choice in my office. If you don't want to take a treatment, then you just have to bear the brunt of it. But I would encourage you to take care of your bones now so that other types of doctors don't have to take care of your bones later. And it's always a bad and very unhappy treatment, and painful as well. This is the end of my lecture, and I would encourage you to take care of your bones now so that we don't have to take care of your bones with other types of doctors and painful procedures later. I would encourage you to go to your doctor and ask for preventive therapy and change your lifestyle so that no smoking, decrease your coffee intake, decrease your soda intake, and definitely exercise with weights, not just swimming, although I love swimming for your heart, but something that has weight-bearing exercise is good for your bones. And it is always good to exercise 3 times a week. Please be preventive. You can choose not to do this, but you'll be sorry later. And I would prefer to see you when we're preventing illness than to see you when we're trying to play catch up and fixing illness. And I have to send you to a specialist for orthopedics or some other osteoporosis type secondary physician who's got to take care of the problems of osteoporosis, like pain management. I hope that you're healthy. You can live a healthier life if you prevent disease, and especially this disease.